كذا دكتور، وإن شاء الله راح نبدأ. بس دقيقة أسوي شير. أوكي. أوكي دكتور. we're live.
السلام عليكم ورحمة الله. بسم الله والصلاة والسلام على رسول الله. Welcome everyone. Good evening, everyone, and welcome to our educational event tonight. This is a webinar, part of Saudi Society of Bone Marrow Transplant webinar series in collaboration with Bristol Myers Squibb PMS sponsorship. Tonight we have a special guest, and tonight we will talk about revolutionizing low-risk MDS treatment, the next generation of care. This is Badr Al-Ahmari. I'm a consultant, stem cell transplant and cellular therapy from King Abdulaziz Medical City National Guard Hospital in Riyadh. So we will move to the next slide. Again, would like to thank PMS for the sponsoring this event. I hope the slide is working. Yes. Okay. So as we all know, myelodysplastic syndrome is a kind of heterogeneous clonal hematopoietic stem cell disorder that is really heterogeneous in terms of presentation and outcome and prognosis. It also starts to be a kind of genetically defined disorder where there are subset of myelodysplastic syndrome that is genetically defined by certain genetic mutation according to the recent WHO criteria, such as SF3B1 MDS. It's a disease of elderly with a median age at diagnosis of above 75. It has a different spectrum of presentation. However, the overall survival for patients with myelodysplastic syndrome is still dismal compared to the other hematological malignancies and also non-hematological malignancies as well. Tonight, we have Prof. Tariq Abu Zaid. Prof. Tariq, it's my pleasure to introduce him tonight. He's a professor of hematology and bone marrow transplant, Faculty of Medicine, Mansoura University, Egypt. And he's also consultant of hematology and stem cell at Al Muwassa Hospital, head of internal medicine department in Dammam, Saudi Arabia since 2016. Dr. Tariq having 26 years of experience in managing benign and malignant hematological disorder, as well as bone marrow transplant, having 64 international publication and 6 other as under publication. It's my pleasure to introduce Prof. Tariq, who is going to give us a talk tonight about management of low-risk myelodysplastic syndrome. Prof. Tariq, the microphone is yours.
First of all, many thanks, dear colleague and friend, Dr. Badr Al-Ahmari, for this nice introduction. And many thanks for the SSBMT for giving me the opportunity to attend and to speak today. Our special thanks goes for PMS for sponsoring this event. I'm going to share my screen. Today, we're going to discuss the next generation management of low-risk MDS. Anemia is a hallmark of MDS that, along with various clinical sequelae, can result from ineffective erythropoiesis. And as Dr. Badri just mentioned, that the pathogenesis of MDS starts by colonal expansion of bone marrow progenitor and dysregulation of bone marrow microenvironment as a result of genetic and chromosomal abnormalities. As a result of that, there will be increased production of dysplastic cells, increased level of apoptosis, leading to different levels of cytopenia. This ineffective erythropoiesis resulting into anemia with poor tissue oxygenation and fatigue, iron overload leading to cardiomyopathy and liver fibrosis, and abnormality in the bone marrow microenvironment leading to stromal dysfunction and other cytopenias. When we look to the actual pathogenesis that leading to ineffective erythropoiesis, it comes from the interaction between the transcriptional growth factor beta superfamily ligand with its interaction with the activin receptor type 2B, leading to activation and autophosphorylation of SMAD2/3 pathway. As a result of that, there will be inhibition and maturational arrest of the erythropoiesis, leading to increased level of apoptosis and different levels of cytopenias. The overall survival in MDS varies significantly according to the risk category. However, even low-risk MDS patients suffer from substantial loss of life. If we compare the very low-risk MDS having median overall survival about 8.8 years compared to the very high-risk MDS 0.8 years in between the different risk category. Therefore, even low-risk MDS having a substantial probability for death due to the disease. The severity of anemia in MDS, which can be defined by hemoglobin level and or RBC transfusion requirement, impacts the patient's survival. As compared to the hemoglobin level, when we say the patient with high hemoglobin level in low-risk MDS, as defined as patient having at least 10 or more gram per deciliter, they having overall survival of 5.5 years, whereas severe anemia, as defined as hemoglobin less than 8 gram per deciliter, they have 5 year survival of 2%. Therefore, there is a discrepancy between the hemoglobin level and the overall survival. And also the RBC transfusion requirement compared when we look for the frequency of transfusion units per month, patient with having 0 unit transfusion per month, having best overall survival compared to patient requiring 1, 2, 3, or 4 units. Therefore, the more the transfusion requirement, the severity of anemia are affecting the patient's survival. Also, when we look for the overall survival in transfusion independence and transfusion dependence, the median overall survival in transfusion independent low-risk MDS is around 100 months compared to 45 months in patients with RBC transfusion dependence. Others is the non-leukemic death and the AML transfusion. Transfusion independent, okay, are having higher survival compared to transfusion dependent low-risk MDS, and also the transfusion dependent have high risk for leukemic transformation. Therefore, leukemic transformation and non-leukemic death is higher in transfusion dependent and in severely anemic low-risk MDS. What is our treatment goal in low-risk MDS? Is to achieve RBC transfusion independence, obtain hematological improvement, improving quality of life, and improve overall survival and delay the AML transformation. But this goal of therapy is quite different. We know that, as Dr. Badr mentioned, that MDS is a big scope of disorders, starting from the low risk to the intermediate to the high risk. In the low risk, we should focus on improving symptoms and transfusion requirement, whereas in the high risk MDS, we should focus on improving the survival. With the advance in the molecular biology and diagnostic technology, a lot of mutational changes has been identified and genetic abnormalities. The most frequently seen in the low-risk MDS are including the SF3B1 and TET2 mutation, followed by 5q deletion and DNA methyltransferase 3A abnormalities. With the use of this molecular, we have redefined and reclassified MDS. If we look for the traditional IBSS risk scoring versus IBSS molecular scoring, we will see a quite difference. According to the IBSS risk scoring, 77% of the patient will have low risk MDS and around 5-year survival. With the advances in the molecular biology and the addition of new genetic abnormalities, we have reclassified the patient, and we found that almost only 58% of the patient of MDS are having lower risk. Therefore, we have now lower incidence of the lower risk, and the percentage of moderate to high risk are increasing with the addition of mutational status. The goal of therapy will remain the same with the advances in molecular, in spite of the reclassification of the patient. According to the recent NCCN guideline to treat myelodysplastic syndrome in the low risk category, first of all, we have to define if the patient harboring 5q deletion or not. If the patient is non-5q deleted, we are looking for the percentage of ringed sideroblast. If the patient is having more than or equivalent 50% ringed sideroblast, or having ringed sideroblast equivalent or more than 5% with SF3B1 mutation, the first line of treatment will be in the form of luspatercept. If the patient is showing no response, we will measure the EPO level. If the patient is having high EPO level, we can consider lenalidomide. And if very famous IMiD, if the patient is having low level of EPO, we can consider EPO replacement, either epoetin alpha or darbepoetin. If the patient is having no response or even not responding to lenalidomide, we can consider IVOS if the patient is having IDH1 mutation. What about the bigger percentage of these patients that having ringed sideroblast less than 15% or ringed sideroblast less than 5% with an SSBMT mutation? We also measure the EPO level. If the patient is having EPO level equivalent or less than 500 microunit per milli, the preferred line of treatment will be either replacement, whether epoetin alpha or darbepoetin. Other recommended is luspatercept. If the patient is a responder, we continue with the treatment with dose de-escalation or escalation according to the response. If the patient is not responding, here are some suggestions. The addition of lenalidomide to epoetin or darbepoetin. If the patient has been treated with ESA, we can shift to luspatercept. If the patient is not a responder to any of them, we can look for IDH1 IVOS inhibitor. What about patient having high level of EPO? If the patient have good tolerability to intensified immune suppressant therapy, we can consider ATG, cyclosporin, and eltrombopag. If there is no response or intolerance, we can follow the number 3. If the patient have poor probability to respond to immune suppressive treatment, the clinical trial, or the patient may reveal azacitidine as a hypomethylating agent. Other preferred is decitabine or oral decitabine or oral other hypomethylating agent. We can consider also lenalidomide. If no response to that, we can look for either IDH inhibitor, or we can look for transplantation. This makes the treatment algorithm more easier if we look for the first line and second line treatment. If the patients have 5q minus syndrome, we look for lenalidomide. Isolated anemia and very low risk features, we consider ESA or luspatercept as frontline treatment. If the patient is having ringed sideroblast, okay, post ESA, we can look for luspatercept. Other low risk with more than one cytopenia, hypomethylating agent or targeted approach. Second line, we can look for hypomethylating agent or allostem cell, addition of lenalidomide, and also sometimes we can look for investigational treatment. What makes low risk MDS quite challenge? Because some of the patient may be diagnosed late, and as Dr. Badr gonna share with me this experience, that some of the patient with low risk MDS having isolated anemia may be treated by internists for a long time until they become referred to the hematologist. Therefore, we cannot estimate the time of diagnosis for that patient. But when we look to the addition of EPO plus growth factor have improved the survival in MDS with low RBC's transfusion need. If we look to the comparison between the RBC's transfusion requirement and their response to EPO, we will look at patient requiring one or less unit per month of transfusion, okay, are having 56% reduction in the risk of death and AML transformation compared to patient receiving 2 or more units of RBCs per month when they are treated by colon stimulating factor plus EPO replacement. Also, Achieving erythroid response can improve survival in low-risk MDS. When we compared either treated and untreated patient in the transfused and non-transfused, we will look in the untransfused low-risk MDS patient treated with ESA having a higher overall survival compared to the ESA untreated patient, while in the transfused patients, they respond the same. Also, when we look to the overall survival, ESA treated patient, okay, in the non-transfused having overall 5 years overall survival around 64% compared to almost 40% in the transfused patient, which means the non-transfused respond to ESA much more better than those with transfusion requirement. But what is the problem of ESA? 2/3 of the patient have low risk with low risk MDS are either refractory or relapsing to ESA. If we look, only 32% will have persistent response to ESA. 29% of the patient who respond initially will eventually relapse, whereas 39% of the patient have primary resistance to erythropoietin stimulating agent, which make that 68% are either primary resistant or having relapse. This is the problem we are facing with EVO as a frontline treatment for low risk. Therefore, hypomethylating and lenalidomide are the most common treatment for post-ESA in the past. However, most of the patients will continue to receive RBC transfusion only in the post-ESA treatment. What about luspatercept? When we look to luspatercept in MDS, luspatercept is a transcription growth factor superfamily ligand inhibitor, whereas when we look to the pathogenesis, it's better in the next slide. Luspatercept come to interact with transcriptional growth factor beta superfamily ligand, and one is interact with it, it prevents its interaction with activin receptor type 2B, and subsequently it prevents the activation and phosphorylation of SMAD2/3 signaling pathway, which relieves the suppressive action on the erythropoiesis, allow erythropoiesis to proceed in the normal pathway, leading to maturation and proliferation of the normal erythroid progenitor into mature cells. Therefore, when we have luspatercept, we are enabling the normal events and ineffective erythropoiesis will be eliminated, which means that the mechanism of action that luspatercept allow able to act on the colony stimulating factor erythroid, leading to maturation proliferation of the normal erythroid pathway, which can improve the anemia. And this has been shown in 2 phase 3 trials. The first is the Middle East phase 3 trial. Initial data has been released in the year 2018, and subsequent data has been released in January 2023. The key eligibility trial of this phase 3 trial Middle East is lower risk MDS or intermediate risk, having 15% or more ringed sideroblast or having 55% ringed sideroblast with SF3B1 mutation with less than 5% in the marrow blast cells. Non-5q deletion, average transfusion requirement were more than 2 units Q8 week. Patient should be either refractory, intolerant, or naive. No prior treatment with disease-modifying agent like IMiD or hypomethylating drug. It has been randomized 2-to-1. Okay, the first arm received luspatercept 1 milligram per kg subcut Q3 versus placebo. And when we look to the treatment and follow-up duration rate, the primary endpoint with that RBC transfusion interval more than or equivalent 8 weeks. During the first 24 weeks, the data has been released 2018. Almost 38% of the luspatercept treated arm has been transfusion interval more than 8 weeks compared to 13.2 in the placebo arm. As by Jan 2023, the median duration of treatment were over 50 weeks, and the entire treatment period data revealed that almost half of the patients treated with luspatercept have achieved transfusion interval more than or equivalent 8 weeks compared to 16% in the placebo arm. Moreover, transfusion interval more than or equivalent 16 weeks has been seen in almost 31.4% of the patient compared to 7.9, which means that I have half of the patient requires transfusion interval more than 8 weeks, and almost 1/3 of the patient requires have achieved transfusion interval more than 16 weeks. And when we look for the duration of transfusion interval more than 8 weeks, we have 56% reduction in the risk of transfusion dependent after 8 or more weeks of transfusion interval, whereas patient requiring transfusion interval more than or equivalent 16 weeks, we have 68% reduction in the risk of transfusion dependence, which means that patient will have transfusion independence. Okay, the higher the transfusion interval, the better the response for the patient. When we look in comparison between both arms, median follow-up in months in the luspatercept treated arm was almost 14 months compared to 38.7. Median duration of treatment 50.9 months compared to 24 months. Transfusion interval more than or equivalent 8 weeks during the first 24 weeks has been seen in 37.9% compared to 13%. Transfusion interval more than or equivalent 8 week entire treatment period has been almost 49% compared to 15.8%. Transfusion interval more than 16 weeks, we are talking about 31% compared to 7.9%. Median cumulative duration of transfusion interval more than or equivalent 8 weeks, we are talking about 110 months compared to 21 months. Median cumulative duration of transfusion interval more than or equivalent 16 weeks, 130 months compared to 94 months. These data show that advantage of luspatercept in patient with low-risk MDS. What about safety issues? Safety issue is progression to higher risk MDS or patient progress to AML. Initial data revealed that only 5.9% progress to high-risk MDS compared to 3.9% in the placebo arm, but what was of good importance that 2.6% in the luspatercept treated arm has progressed to AML compared to 3.9%. Therefore, there are no safety concern. The relation between fatigue and the luspatercept treated dose and cycle, when we look to compare the fatigue, 60% of the patient receiving less than 1 milligram per kg still experience fatigue, whereas when we increasing the dose to 1.33, it is 39%, 1.75 milligram per kg, 14%, which means that with higher doses, the response to fatigue is less than that. When we look to the cycle, there is a dramatic drop after cycle 4, which means if the patient experiences fatigue, this fatigue will be eliminated after the fourth injection. According to the hemoglobin level, definitively patient having hemoglobin equivalent or more than 10 grams per deciliter will have less fatigue compared to patient having hemoglobin less than 10 grams. At the end of this Middle East, after more than 6 years of follow-up, patients with low-risk MDS who received luspatercept for more than 2 years longer than in the original Middle East trial experienced sustained transfusion independence. 41.3% and 64.6% of the patient achieved either transfusion interval more than or equivalent 8 weeks or more than or equivalent 16 weeks, respectively. The rate of transfusion interval response increases with the treatment time. The long-term safety profile of luspatercept treated arm was favorable. No progression to high-risk MDS or AML event has been reported since the data initially released in 2018. Fatigue was transient as previously reported, and the rate of fatigue decrease was increasing the hemoglobin level. These data demonstrate the long-term efficacy and safety of luspatercept in patients with low-risk MDS who were either intolerant or refractory. Okay, this make us move to the second phase 3 trial, the COMMAND trial. The COMMAND trial is the comparison between luspatercept versus ibutine alpha in ESA-naive low-risk MDS patient. In the Middle East, we were talking about either refractory or relapsing patient. Here in the COMMAND, they included IBS very low or intermediate risk MDS patient. Having RBC's transfusion requirement 2 to 6 unit Qs 8 weeks, endogenous EPO level less than 500, ESA naive, and the patient with 5Q were excluded. They were randomized 1-to-1. The first arm received luspatercept 1 milligram per kg subcut Q3 versus ibutine alpha 450 international unit per kg subcut Q week, titration up to 1050 international units. When we look to the primary endpoint achievement, luspatercept significantly improved RBC's transfusion interval versus ibutine alpha, 60% versus 34%. And when we look in the entire study group, okay, 60.4% of the luspatercept treated arm achieves the primary endpoint compared to 34.8 in the ESA arm. When we look to different patient category, according to the baseline transfusion burden, those receiving less than 4 unit Q8 weeks, okay, almost 66.9% in the luspatercept treated arm receives the primary endpoint compared to 43.2 in the ESA treated arm. Patient with heavy transfusion burden, more than or equivalent 4 unit Q8 week, we are talking about 48.4% in the luspatercept treated arm compared to 21. Therefore, patient either transfusion burden high or low, luspatercept treated arm are having higher response compared to ESA treated arm. What about baseline EPO level? Patient was having very low baseline EPO level, 66.2% in the luspatercept treated arm are achieving primary endpoint compared to 41.0% in the ESA. And this is fascinating because we were believing that the patient with very low EPO level gonna respond much more better to EPO compared to luspatercept, but here we show the difference. Patient having 200 to less than 500 unit per liter EPO level, also 37.8 in the luspatercept treated arm compared to 10.8% in the EPO arm. According to the mutation, definitively SF3B1 mutated, they respond much more higher in the luspatercept treated arm by 70% compared to 32 in the EPO arm, unmutated 44 compared to 36, still also higher. What about the presence of ringed sideroblast? Patient with more than 15% ringed sideroblast, we are talking about 2/3 of the patient in the luspatercept treated arm are responder compared to only 30% in the EPO arm. Patient without ringed sideroblast is almost the same. And when we look to the next slide, pre-planned exploratory analysis of transfusion independence during the first 24 weeks, the response rate of transfusion interval for 24 weeks were greater in the luspatercept treated arm versus ibutine alpha, regardless the baseline transfusion burden, serum EPO category, or SF3B1. And also, here, if we look to the total treated population, 63% of the luspatercept treated arm achieved this transfusion interval compared to 42% in the EPO level. According to the baseline transfusion burden, low transfusion burden, also higher response rate in the luspatercept treated arm compared to the EPO. High transfusion burden, also they respond well to luspatercept treated arm compared to the EPO. According to the baseline EPO level, is it extremely low or it is low? Also, it is higher in the luspatercept treated arm compared to the erythropoietin stimulating agent. Also, according to the mutational status of SF3B1 mutation, the mutated one, definitively they are responding higher in the luspatercept treated arm. Also, the non-mutated ringed sideroblast, also the presence of ringed sideroblast higher in the arm, which mean response rate to RBC's transfusion interval for more than 24 weeks are greater in the luspatercept treated arm compared to the ibutine alpha, regardless baseline transfusion burden, EPO level, or SF3 mutational status. When we look to the duration transfusion interval more than 12 weeks, okay, till the end of the treatment, we will see that in the luspatercept treated arm, we are talking about around 126 weeks compared to almost 90 weeks in the EPO treated arm, which associated with 41 reduction in the risk of transfusion dependence. When we look to the comparison in different patient category, patient having ringed sideroblast or patient without ringed sideroblast, okay, we have almost around 121 weeks median transfusion interval compared to 61 weeks in the luspatercept treated arm. And when we look to the ringed sideroblast absence, okay, we are talking about nearly close to each other, but we are talking about 35% reduction in the risk of transfusion dependence after 12 weeks of treatment in the ring etc. and 29% reduction in the risk of transfusion dependence after 12 weeks of treatment transfusion interval in the ring etc. negative patient. According to different hematological improvement, okay, total hematological improvement has been seen in almost 75% of the luspatercept arm compared to 53% in patient with the EPO treatment. Hematological improvement as regards the neutrophil, 33% compared to 25%. Hematological improvement regarding platelet count, 42% compared to. Therefore, luspatercept not only improving the RBCs, it improving also the neutrophilic count, improving the platelet count in the patient with low-risk MTS. Safety concern, there is no safety concern. And also, when we look for the most important is the fatigue, diarrhea, and it is comparable in both arms. And it is the summary of the command trial. Therefore, here is a role model for the early use of luspatercept in the treatment pathway leading to benefit in the survival. We compare the luspatercept frontline treatment plus best supportive care compared to ESA frontline treatment followed by luspatercept as second arm. Total months of treatment in luspatercept treatment arm, we are talking about 54.7 compared to 49.3 months in the patient receiving luspatercept as second arm. When we look to the responder, almost 60% will respond to luspatercept in the frontline treatment compared to 40% in the luspatercept second line, which means early use of luspatercept, higher incidence of responder compared to the use of ESA first, then followed by luspatercept. Months of life as transfusion interval in the frontline luspatercept, we are talking about 22.6 months transfusion interval. Luspatercept second line following ESA, we are talking about 15.7 months, which means there is improvement in the transfusion interval. Overall, 27% of the patient will have transfusion interval higher ratio in luspatercept frontline compared to 4.4% second line luspatercept. When you look to annual RBCs unit, we are talking about luspatercept frontline treatment 11.8 compared to 13.4. Okay, after the therapy, it reduced to 10.9, whereas in the luspatercept second line, it becomes 17.9. Therefore, this role model suggests that the earlier usage of luspatercept in low-risk MDS, the patient responds in higher rate, and the transfusion interval will be prolonged. And this is from the last ASCO. Luspatercept is effective treatment option for patients with low-risk MDS and anemia. Luspatercept was associated with improved rate, in the rate of RBC transfusion independence and increased hemoglobin level as compared as ibrutinib alpha in ESA-naive patient as confirmed by the command study. Higher doses of luspatercept may be often required for efficacy. We start with standardized dose 1 milligram per kg and to be increased to 1.33 up to 1.75 milligram per kg. And now it is approved for the management of patients with ESA-naive low-risk MDS based on the data from the phase 3 commanded trial and its prior approval for ESA-refractory low-risk patient. What about if my patient failed to respond to even luspatercept? According to the MDS 004, the randomized phase 3 study of the use of lenalidomide in low-risk MDS patient with 5q deletion, the LIN5 and LIN10. And this there is comparison with the usage of lenalidomide 5 milligram versus lenalidomide 10 milligram for patient having 5q minus syndrome. When we look to the RBC transfusion independence in weeks, okay, 43% in the patient receiving lenalidomide 5 milligram are having transfusion interval more than or equivalent 26 weeks compared to almost 56% in lenalidomide 10 milligram. And this is an advantage for the lenalidomide 10 milligram. Median duration of transfusion interval has been not reached. Median maximum hemoglobin increase in responder, we're talking about 5.2 gram per deciliter hemoglobin rise average in lenalidomide 5 milligram. We could achieve it 6.3 gram per deciliter. Complete cytogenetic response or partial cytogenetic response, we are talking about 25% in LIN5 compared to 50% in lenalidomide 10. Progression to AML, we are talking about 2.9% in patient having LEN5 and 0 in patient receiving LEN5, which means lenalidomide 10 milligram, much more potent in patient with 5q- syndrome. According to the adverse event and treatment-related toxicity, grade 3 to 4 neutropenia has been seen in 74% patient receiving LEN5 and 75 in patient receiving LEN10. With the usage of LEN10, also the safety issues is comparable to LEN5. Discontinuation of the treatment due to adverse event has been seen in 17% of the patient receiving LEN5 compared to only 9% receiving LEN10. What about others, like hypomethylating agent? Survival with low dose decitabine or azacitidine versus historical outcome in low-risk MDS. When we look at patient with low-risk MDS receiving azacitidine having 52% overall survival, and patients with intermediate risk MDS have using hypomethylating agent, we are talking about 38% 5 years overall survival, and patients with high risk, we are talking about 22%. Yes, definitely it's acceptable that the percentage is decreasing with the advantage of the disease, but it is still a treatment option, low dose hypomethylating agent for patient having refractory low dose. What about others? Okay, according to the Monte Carlo analysis, the impact of early RIC allogenic stem cell transplant survival versus standardized treatment, we saw that non-transplanted having prolonged overall survival compared to patients with reduced intensity transplant. Therefore, patients with low risk MDS very seldom need to go for reduced intensity stem cell transplant. And the outcome in patients with low risk MDS post hypomethylating agent failure, we are talking about 17% over 17 months median overall survival for patient not responding to hypomethylating agent. What else? Patient with low risk MDS post hypomethylating failure, salvage therapy. We have either to look no therapy, conventional, allogenic, or investigational. Generally speaking, patient receiving allo stem cell post hypomethylating therapy achieve significantly improved survival versus those receiving no further treatment. Therefore, we keep the allogenic transplant in low risk as a last option after salvage therapy failure for patient with low risk. In conclusion, molecular data help to identify true low risk MDS. As we mentioned before, the IPS risk scoring, we're grouping 77%. With the molecular data, we are talking about 58%. Development of approval for new agent in low-risk MDS like luspatercept, imelalisate, or KIR50. Imelalisate has been approved recently in last June. Future direction, target medication, combination strategy, targeting platelets, targeting transfusion independence, role of stem cell, and modulation comparative. Now we have too many treatment options, and we're looking for more for patients with low risk MDS, and the future carry more and more. And at the end, luspatercept is indicated in the low risk MDS, either frontline treatment or after EPO failure. And I'm gonna thank the audience, and the floor is open for question.
Well, thank you very much, Prof. Tariq, for this wonderful presentation. And it's an interesting topic and interesting talk about the low risk MDS. We've learned a lot from this presentation, of course. I would like to remind the audience that they can still submit their questions under the Q&A section. If they have any question for Prof. Tariq. So I have a question, Prof. Tariq. In your practice, do you do NGS testing for all MDS patients? And for example, if you have like a low risk MDS, do you incorporate this into your practice to do the NGS testing?
Yes, unfortunately, we are doing that in high risk patient only. And because we are doing that, we sending that abroad. But I try to expand the panel to do it also for the low risk, because it will affect the treatment strategy definitively.
Yes, I agree with you. I agree. I mean, sometimes there are challenges into like
Yeah.
ordering these tests, especially if it's not available in house for MDS. And I think there are recent paper published in JCO where the utilization of the IPSS-M, the modified or molecular IPSS, was more accurate in terms of assigning patient whether to go for immediate approach for transplant or no
Yeah.
transplant. And what was interesting there actually that around 20% of patients in the low risk actually they were actually changed into high risk
High risk.
on
Yeah.
the NGS, indicating the necessity to do this even for low risk
Yeah.
MDS.
Definitely. As you mentioned, Dr. Badr, yeah, before we were talking about two-thirds of the patient or more than that are low risk, okay? With the addition of molecular testing, now we are talking about only less than 60% of the patient are low risk, and around 14% of them have been moved to intermediate and high risk. And also with the molecular testing, we can identify the patient who gonna be refractory to the traditional treatment, who should go immediately for transplant and put transplant in an early stage. I think day by day with the introduction of NGS and the wide usage of NGS, we're going to learn more about this patient. The same as we have also changed our treatment strategy in myelofibrosis. Before myelofibrosis, we were putting the patient into the traditional line of treatment with the JAK2 inhibitors, and if the patient failed, we go for transplant. With the addition of molecular testing, we know that some of the patient gonna not respond to the traditional or the JAK2 inhibitor and necessitate the early transplantation. Therefore, I think NGS usage has to be used in an early cases also.
Yes, absolutely. I agree with you. With regard to I'm still looking to the Q&A here. Again, if there is any questions, please submit to the Q&A section, please, audience.
I have a question for you, Dr. Badr. Do
Sure,
you
sure.
also see some of these patients maybe misdiagnosed and become referred to the hematologist lately?
I mean, the low risk MDS, yeah, I mean, I think if there is an anemia, this should be handled by hematologists directly. I mean, you cannot assume this is, let's say, simple iron deficiency anemia where you infuse a lot of iron for those patients. Because as you mentioned, like early recognition and intervention is very crucial here because the treatment approach is totally different.
Yeah.
I mean, doing the basic testing, like ruling out iron deficiency anemia or B12 deficiency, which is not common.
The problem is also in the 5q deletion, because 5q deletion is more common in females. This is one item. And in our locality, we are accepting female to go around with having hemoglobin around 9 and 10. Okay, it's accepted for them. Okay, no one is taking a deeper look for this low hemoglobin until the patient may progress to intermediate or high risk.
Absolutely. So thinking that this is iron deficiency and some iron from any local clinic, and yeah, it is really important to address this aspect because there are effective treatments nowadays in upfront setting that can make patient transfusion independent and improve the outcome. I mean, what's interesting for talking about patients with anemia but not transfusion dependent, especially the 5q syndrome. There has been a recent randomized study. I think it was a Spanish trial where they randomized patients actually between those who are transfusion independent but they have anemia and they are with 5q syndrome. They were randomized between lenalidomide versus placebo, and after 5-year follow-up, there was clear improvements in the outcome with patients who are in lenalidomide, where like the median time to transfusion dependency was actually 11 months for those who were in placebo, and it was not reached for patients who were in lenalidomide. And there were actually, of course, we know that can lead to cytogenetic remission.
Yeah.
There was higher rate of cytogenetic remission for those who are on lenalidomide arm. I couldn't find any publication for that study. I saw it in one of the I think ASH or EHA presentation like 2 years ago, but I couldn't find any publication related to that. Rhonda. But
Yeah.
it's an important study that answer an important question whether to initiate lenalidomide early on for patient with 5q syndrome.
However, any treatment that can lead to transfusion independence or increase the frequency or decrease the frequency of transfusion should be tried, because transfusion, okay, is a big obstacle in our locality. Some of the physicians consider blood transfusion as an easy maneuver, okay? And according to the American Peripheral Blood Management, okay, we should avoid the transfusion as much as we can. Any treatment that can lead to transfusion independence should be tried first, because with transfusions there is a lot of risk. There is a burden on the hospital bed, there is a complication from the transfusion, and also if the patient is elderly, there is also a problem to transfer the patient to the hospital for blood transfusion. Therefore, when we look to the data from the luspatercept with transfusion independence up to 16 weeks or more, in improvement in the patient requirement. When we look for LIN10 versus LIN5 in the 5q minus syndrome, we are talking about almost 126 weeks or more transfusion independence. It's equivalent to 6 months.
Yeah, absolutely. I agree with you. I have a question here from the audience. Prof. Tariq, ring sideroblast negative MDS, low risk MDS. The question: would you use innovative therapy for it, such as luspatercept, or are you going to use other? I'm assuming here the question is about ring sideroblast negative MDS as a first line for transfusion dependent MDS. Would you use luspatercept or others?
First of all, according to the Middle East recommended trial, ring sideroblast negative patient, they respond, okay? When in comparison to EPO, they respond well, and also in the Middle East. But according to the guidelines, okay, it shouldn't be. Only the patient with ring sideroblast and SF3B1 mutation.
What about in upfront setting, according to the command study?
According to command, we can use it, okay, according to command study, but not according to guideline. Here it is a challenge, okay? It will be physician dependent. You have to choose. Me, myself, I'm gonna go for luspatercept, because I'm a little bit kept according to the command that patient with ring sideroblast negative is still having higher response compared to the EPO. Okay, I'm gonna go for luspatercept.
Yeah. Yeah. Although the subset of patient in the command study with the ring sideroblast, still their response is not as those who are ring sideroblast
Positive. Yeah.
So it's still it's kind of a debatable area whether to go
Yeah.
for luspatercept or just go with the traditional therapy for ring sideroblast negative. But for ring sideroblast positive, I think
Definitely,
this is
I'm gonna go. Yeah.
the patient that's going to really benefit from this. I agree with you totally. Let me check if there is any. In your experience, Dr. Prof. Tariq, do you have you seen any of the adverse? Because there are a list of adverse events that you usually see with luspatercept. To be honest, myself, I did not see any of these adverse events that mentioned that it was associated with the use of luspatercept in the both study, especially the diarrhea and others, and the fatigue as well. In your experience, have you seen any of
Yeah, I see a lot.
How tolerable it is, the treatment, and how do you
Uh,
manage their side effects?
Yeah, it's manageable arthralgia or bone ache, manageable arthralgia, bone ache that is resolving sometimes by fades away or sometimes by paracetamol only. It's not so annoying for the patient, but it is recognized that some of the patient developed arthralgia or bone ache. Diarrhea, I have not seen patient develop diarrhea.
Thank you. So one more question about although in the study they were not combined, that combining erythropoietin
Luspatercept.
with the luspatercept. In your practice, do you still continue the erythropoietin when you decide that patient, okay, failed erythropoietin, and then I need to shift into luspatercept? Do you still continue the use of erythropoietin, or you just stop the erythropoietin and continue luspatercept?
Actually I had two patients were well responder to erythropoietin, and when they start to lose response and become transfusion dependent again, these two patients particularly, I added luspatercept. I did not stop the darbepoetin. I added luspatercept, okay, and they regain transfusion independence again, okay. But in the vast majority of the patient, I stop erythropoietin and go for luspatercept. But
Excellent.
even by combination, the response is acceptable and marvelous. But you have to look from the point of view the cost of the combining medication and the toxicity.
Yeah, toxicity and whether there is a benefit or not. Although there are
Yeah,
some available like retrospective data, but
yeah.
we're not sure about the actual benefit of this combination. Yeah. Do you have a certain subset of patient that or predictor, let's say predictors of response for patient who are SF3B1 mutation? We know that SF3B1 who are refractory to
Perfect.
it, based on the study, they do respond. However, unfortunately, still a good fraction of patients still they have difficulty to achieve transfusion independence, even with the novel therapy such as
Yeah.
luspatercept. So what are the predictors that, according to the study, that showed this subset of patient might be the most beneficial patient they're gonna respond to the treatment?
I think the patient who were not the transfusion burden will be important. Patient with very high transfusion burden, those receiving 4 or more unit Q8, okay, their response will be not compared to those receiving less than that, okay. But also every now and then it emerges a patient that cutting the cycles and emerges. We have seen a patient with low transfusion burden and not responding, and patient with high transfusion burden and rapidly responding. Therefore, I think initial assessment should be taken in the first 4 injection. If the patient transfusion interval is not improved, okay, I will go for another 4 injection, and if not, I'm gonna stop, because sometimes the patient remains transfusion interval as it is. When we talk about 8 injection, it means almost around 6 months. If the patient during the first 6 months, okay, remains with the same transfusion frequency, okay, he gonna not respond later on.
I see. All right, and I think also I think patient with
The comorbidities affecting also the comorbidities, advancing of the age, and let me say briefly, any patient with MDS, when he failed to any line of therapy, okay, before changing the line, you have to reassess the patient again by bone marrow examination and also the mutational status, because sometimes the patient may progress to other risk groups. Sometimes he developed or adding a new mutation, because the baseline mutational status may be also adding 1 or 2 other mutations that may change our treatment decision.
Yeah, I totally agree. And I think also one of the things is presence of thrombocytopenia. Also, it's kind
Yeah.
of a predictor of poor response to
Yeah.
to this kind of therapy. All right. I think we have no more questions from the audience. Yeah. So I think we'll have to conclude our session tonight. In the end, I would like to thank Prof. Tariq. It's a pleasure to be with you tonight and presenting this nice data about the management of low risk MDS. And I hope all the audience has benefited from the interaction tonight about the and the discussion about the low risk MDS. And I hope that we add some knowledge and benefit to our audience. I would like at the end to thank the Saudi Society of Bone Marrow Transplant for giving me the opportunity to moderate this session tonight, and also thanks to the Bristol Myers Squibb for the sponsoring the event tonight. Thank you, Dr. Tariq, and
Thank
thank
you,
you to
Dr.
the
Bar.
audience, and hopefully to see you in another webinar series from the
Inshallah.
SSBMT. Thank you and have a
Thank
good
you.
night.
Thank you. Have a good night.